which again has got quite a long 8 to 10 centimeter anterior extramuscular course before it gives off to certain perforators. And these are the set of perforators. And in the last couple of years, or maybe around 5 years or so, people have devised a large number of flaps based on these perforators. Most of them are microvascular flaps called the TDAF flap. And though anatomically, if you look at these pictures, these were the old times when we used to know, based on our knowledge of anatomy, how the latissimus dorsi would be placed and how we will take the flap. And then gradually with time, we understood that there are certain areas where the lower perforators of the thoracodorsal pedicle is likely to be present. And then people started devising newer flap based on the location of the perforators. The issue again is it worth only to know the anatomy and go ahead with the perforator marking and go ahead with the perforator flap, or to extend beyond that to certain complex forms of radiology? And we are going to see how beautifully in certain circumstances it helps us in devising and planning a wonderful flap. And in the last 5 years, we have shifted in appropriate cases to this autologous latissimus dorsi myocutaneous flap after a skin sparing mastectomy, and it gives a good fill up. But again, one has to be very sure and certain about the vascular anatomy and how you can use a larger latissimus dorsi belly. And we would really want the radiology to come a better place in this perspective, helping us to plan a bigger flap in such circumstances. Now, this is a flap that we have used quite frequently after wider local recurrences in the skin after breast conservation surgery. And this is a propeller lie cap where we have utilized and moved on. And when we are using a propeller lie cap, it's extremely important once again to understand exactly where the perforator is, because the margin of error is very less. You should be extremely careful. And this is one area, again, I will show how important is the help of radiology in these particular cases. And coming to the workhorse, the lie cap flap that you see here, and this is the eye cap, that's the anterior intercostal, and there you see the lateral thoracic coming up, and quite often you can utilize a part of them to increase the vascularity of the lie cap flap as well. And the microvascular colleagues can use the L-tap as well to devise a microvascular flap in a better way. I am not a microvascular flap, but my colleagues do help me at times when I need a more robust reconstruction. And then this is the traditional lie cap with the vessel, and this is how after you have deepithelialized the lie cap and put it inside. And presently we are going more into lie caps for a small to moderate defect in a cup B breast, compared to the more common uses of latissimus dorsi that I had shown right at the beginning. The only issue, compared to a latissimus dorsi where the vascularity is extremely predictable and the flap being extremely robust, even for beginners, if he is not drunk, the flap really fails. But when it comes to lie cap, it does have a learning curve which is steeper than the latissimus dorsi myocutaneous flap, and therefore even for a beginner, localization of the perforator does play an important issue. And the fact that at times we put the whole lie cap flap buried, deepithelialized under the skin, might actually lead to a flap necrosis later on, which may remain undiagnosed, and therefore the role of radiology can only be emphasized in these circumstances. And this is a slide from Rishi, my good friend from Lancaster, from the United Kingdom. And you understand the eye cap and the my cap also does have a newer roles to play in the armamentarium of a breast surgeon. And this is again from Rishi. I have not done an ICAP or a MICAP, but I understand this is quite a handy flap to be used, perforator flap to be used for medial defects in certain circumstances. So, coming with this brief introduction about how these newer perforator flaps in the chest wall can play a major role, the role of imaging in perforator flaps, number one in the preoperative circumstances, very simplistically, is localization and patency assessment. That's obviously the goal for most breast surgeon, or at least for beginners who are beginning with like a flap. Intraoperatively, if you're doing a microvascular, it assesses the anastomotic patency, it assesses the vessel flow and the patency as well. So intraoperatively, I will show you certain slides to make you understand that while you're doing a pedicle flap or a perforator flap, the intraoperative assessment can have a major role. And if you're doing a microvascular, definitely it has a major role to play, and the newer modalities does help to a large extent. Post-operatively, the same goals of monitoring the flap and early detection of an artery or a venous block can be handy before you lose the whole flap. So, is it worth imaging? Now, for if we have trainees here, you must understand the basics that an axial vessel is quite constant. And we have been told about the fact that the thoracodorsal, the pathway of the thoracodorsal is very predictable. But the microcirculation after the axial vessel that comes up can be quite wide in the spectrum and can be very wide. Therefore, if you are dealing with a musculocutaneous flap where the flap loss can be between 5 to 10%, while you are using a perforator flap, things can go wrong more frequently because the margin of error is quite low. And therefore, understanding the angulation and the number of perforators and its pathways can be extremely helpful in devising and planning and rotating a perforator flap and reconstructing or rebuilding a local area in the breast. So largely these are the tools, and I would club together the Doppler and the Duplex. I would club together in the chapter 2 of CT angio and MR angio. I would just theoretically touch upon the DART. I don't have whatsoever any personal or real world experience on using this technique, but I do have a very humble small experience of using ICG in the breast surgery, and I will share with you how it can be helpful. So coming to the chapter 1, which is called where we are going to deal with the Doppler and the Duplex scan. Now again, for the trainees, how you deal with and try to locate in a Doppler a particular perforator is extremely important. The technique is you need to put in small loops the Doppler around the expected anatomical zone of the perforator. If you are trying to actually go into the deep of a main pedicle, you can press on it. But if you are looking at a perforator, which is a cutaneous perforator, the touch really has to be very subtle and very faint, because if you press it deep, you are going to miss the perforator flow. Now, this is just a small video to make you understand how exactly the movement takes place at the anatomical location. And this is the small little movement that a trainee should initially train themselves to locate exactly where the perforator is. And this is the movement I am talking about. And it has
size of the perforator acoustic signal দেখলে পড়ে যাবে.
So if you have the acoustic signals, you can actually understand what is the size of the perforator. Now, This is again a short video for newer trainees who want to invest in learning Doppler for assessment of the different chest wall perforators. And the narrative is been given by my junior colleague. And if you just hear it, you will be able to understand how it really works.
This is a handheld Doppler. We are trying to find a perforator from the intercostal artery in the fifth intercostal space. It is aligned to the anterior axillary line, and we find a good perforator with a good acoustic signal. There are two nearby perforators here, as I can see. One having a signal. They are both nearby. The signal gets blurred when we move our Doppler pencil tip away from the perforator. Several other perforators like the T-tap artery perforators, which is found in the posterior axillary line, as I have marked, about 8 centimeter from the lower limit of the axilla can be found. These are very sizable perforators and flaps can be based on them. The advantage being that we don't need to sacrifice the latissimus dorsi for this. Extension to comma, abduction. Here we are getting a signal. So this is one of the perforators of the thoracodorsal artery. And when we compress the signal, that goes away. When we compress our probe, the signal goes away. This is an indirect proof that this is a cutaneous perforator and not the main vessel or the main supply. So like this, we can Doppler map the whole area, and according to our defect, we can plan our flap based on this type of vessels.
So that is how somebody can actually map a large number of perforators. There is actually a sea of perforators which have been navigated out in last 5 years, and somebody can use with the help of a Doppler locating at different anatomical landmarks. You can add a colored Doppler. The advantage being, if you add a colored Doppler, as you see here, you can delineate the perforator visually. We are trying to shift from a handheld Doppler to a colored Doppler. We are going to get it in another couple of weeks' time. The understanding is I will be able to visualize. Number two, it can actually demonstrate the predominant perforator. It's not so important for the chest wall, but if somebody is planning for a TRAM or a microvascular for a DF, they would be able to understand in the periumbilical area which is the predominant perforator and what's the vascular diameter. If you find it more than 2 millimeter, you know that this is the predominant perforator which has been mapped, and you can use that particular perforator. It can also state the flow velocity, and based on the flow velocity, there have been classification of which perforator can be most handy, particularly while you are dealing with DF flaps. Coming to the second chapter, which deals with the CT and MR angio and its role in perforator flaps. Now, CT angio, those who do it routinely, and in my institute, we do not do it routinely except when my plastic surgical colleagues are not very sure about the location of the flap while they are doing a DF. If they have a small laparoscopic scar which has been done previously and they want to be very sure that the perforator has not been damaged, In those circumstances, they would use a CT angio, but there are centers who would routinely use them. It gives you a very precise location and the intramuscular course. And I'm going to show you certain pictures to make you understand how the intramuscular course can be helpful for microvascular surgery. It can give you axial, coronal, and even sagittal views at times to make you understand the course of the perforator right from the beginning and towards the point where it is touching the skin or the subdermal areas. Now, this is a classification based on CT that was devised for DF. So you understand, if you do a CT angio for plastic surgical colleagues, they can have the number of branches of the perforator, and they can also look at the relationship between the perforator and the branching pattern that they have in the dermal vasculature. Now, quite like this. Now, this is again a borrowed picture, and you will find that this is a type 1 branching pattern on the right side, where you have a type 2 branching pattern on the left side. So that gives the plastic surgeon or a microvascular surgeon a clear overview what he is expecting in terms of creating a flap. They can actually, in certain institutes, they can use the subdermal vascularity assessment. But I personally, I would use the ICG more, and I'm going to show you some small videos to make you understand how ICG delineates the flap in a wonderful way. Now, this is again borrowed from one of my plastic surgical colleagues from Tata Medical Center. And there again, you find this is the left, and that's the course, how it is going. And you can add it like this, or you can have it in this view. And in this view, you are able to understand that, look at this perforator, the relationship between the main vessel, it's almost a 90-degree straight view. And this is the parallel flow of the subcutaneous perforator or the branches that you see. And this is what is going to be illuminated better in an ICG. But if you look at the same patient, on the left side, now you have a more acute angle coming up in this particular patient, and that's maybe due to the movement, or that may be due to a real obtusity or acuteness of the angle that is far more demonstrated in a CT angio. This is the same patient, or this is the same patient in another view. And this is a magnified view where you will be able to understand the intramuscular course and the subcutaneous vascular branching that you expect after you have used the dye for angiography. This is again for chest wall perforators, where you can see the delineation of the lateral thoracic vessel quite clearly as it descends from the axillary artery. Now, this is a magnified view of the axillary artery and its course and its branches. And therefore, if you know exactly how it is going, you can plan your main vessel or your perforator breast flap when you choose to use the LTAP in these circumstances. One can, of course, three-dimensionally recreate the whole picture. That's going to give a better picture. Though, of course, we would not normally do that. My plastic surgical colleagues, and I've asked them, they would not normally, if they are happy to understand the predominant vasculature, they're happy with that. One can choose an MR angio.
Mosquito is coming, that's why. Yeah, you can put it on the pillow. No?
Can somebody mute? Thank you very much. So if you have a head-to-head comparison between CT and an MR angio in delineating a DF, I mean, that's the area where it has been maximally experimented. One would understand that the spatial imaging is less with MR, but the vascular imaging is far better. Even they can pick up small perforators better than a CT angio, and the advantage, of course, is the lack of ionizing radiation. So it's an institutional choice. My plastic surgical colleague who do microvascular, when they choose to have, they usually choose a CT angio. There are, of course, areas or centers where they can use an MR angio if they're happy to use that. Not a big difference, but I suppose the smaller vascularities are better predisposed or better visualized in MR angio. The chapter 3 is the dynamic infrared thermography. Now, this is more of a theoretical discussion, and again, for trainees who can take up then in future, it's quite handy. But I have practically no real world evidence on this. And the basic principle of this of DART is that initially you take a picture of the pre-cooling and then you engage on a cooling challenge, and once the surface cooling takes place, there is a relative period of hypoperfusion. Once this hypoperfusion takes place, there is a period, you wait for some time, and then you allow the period of natural rewarming, and the hyperperfusion takes place. What we are going to do is, once the hyperperfusion and the cold phase both are being visualized using an infrared camera, you note the change. It locates the hot spots and you can reconfirm it with your Doppler, quite like the one that you see here. You see here, this is the initial marking. This is again from the book on DART imaging, in the book on perforator mapping and imaging. Now, quite like this, you have already marked the areas where it can actually place. And this is the pre-cooling picture. And then you put the patient on a fan cooling. At the end of 2 minutes, you will find that everything has gone down. So there is no picture. Now you allowed a 1 minute recovery here, and then you go for a 3 minute recovery. Once you have a 3 minute recovery, you will find the hot spots coming up. So these are the hot spots where you expect the predominant perforator branching to be. And then you can reconfirm it on a Doppler about the acoustics that you receive. You can, if you are adding a duplex scan, you can see the vessel diameter, whether it's 2 millimeter, less or more, what is the flow velocity, and then you can decide, well, these are the most two robust perforators, and you can plan a flap depending on your DART finding. But as I said, none of my microvascular colleague has any real world evidence on this, and I won't be able to actually tell you how good or bad it is. Coming to the last chapter, which deals with ICG. Now, this is one area where we have been doing a lot of work, and in fact, this is not the place to discuss, but we have devised a new technique of axillary dissection, preserving the lymphatics under real imaging by ICG, and it just got published in the European Journal of Surgical Oncology, and I was supposed to present it in Birmingham on 18th. I did a digital presentation. What this has done is actually revolutionized breast surgery. There are various techniques by which you can hold the camera. You can use the Japanese one. You can use the one that is being devised by the Stryker. You can use a less expensive model that was devised invented and planned and designed in Bangalore. That's a cheaper version of the camera. But having said that, the main stem continues to be ICG. Now, quite often after the pedicle flap that is being done by us, you might encounter an area of marginal flap necrosis, and you do not have whatsoever any clue, in spite of sacrificing the zone 4, why the margins actually went off. And you do not know what exactly and how exactly. You can only tell by a Doppler it was located here, but you cannot go beyond that. And what ICG can do is it can predict the flap vascularity in a wonderful way. And there are solid and robust evidence. This is one of the earlier evidences where the virtual perfusion reality can be done by this. And there have been multiple devices and multiple innovations on this line. But we have agreed upon is that it really helps. And if we look at this video, which I hired, again, I am extremely sorry. I'm using the logo of Stryker because I borrowed them with this. And so if you find this, you will be able to understand how exactly it works. Now, this is a surveillance of a deer that is being harvested. Now, look very carefully. As you have injected the dye intravascularly, the whole thing is going to glow up with ICG. You can compare with the surrounding area. Now, this is how the subdermal vasculature is glowing up. Now, this is far better than CT in predicting the subdermal vasculature, and it can actually show you, as you see here, the wonderful areas where it is normal and vasculature is maintained, and areas where it has gone really black. And you need to know, you can actually mark the area to be on safer side what you are going to excise and what you are going to keep. And that's the umbilicus, which is also visible. That possibly is a tattoo that you see here lower down. But you can actually understand and discriminate between the well vascularized and the not so vascularized and the ones which are really black. And you can excise and take the whole thing up. Now, this is another video where it's a skin sparing mastectomy. Again, and you are trying to understand whether the vascularity to the nipple areolar complex is well maintained or not. And again, I have put this to make you understand how wonderfully the subdermal vasculature can be eliminated using the ICG and the SPY mode. Again, this is the whole thing is glowing up with ICG. And you can see the whole area of skin sparing mastectomy. You can see the nipple areolar complex that is glowing up. And as time passes, you are able to understand the arborized subcutaneous vessels or the subdermal vessels, and being able to be sure that the vasculature is maintained here. And there's a small scar underneath to suggest through which somebody has put in an implant inside. And we are at present running this study on ICG in axilla, multiple studies, and we are also going to start very soon our study on flaps. And I have discussed with my microsurgical, microvascular colleagues, they are going to utilize it more for that. And we are going to utilize for the perforator, pedicle or the propeller flaps, and try to see how well it can delineate right at the beginning when the surgery is being done. Sorry, it started now. So this is an example of an ICAP where an ICG has been able to delineate properly the flap vascularity. And you can see that the flap is very well perfused, and therefore you know that this flap is going to stay. And mind that when you are going to deepithelialize and go for a PAP technique and bury it underneath the skin, it's extremely important right at the point where you are burying the whole flap inside to understand that the flap vascularity is well maintained, and therefore ICG can be extremely helpful. Whatever camera mode you use, it's up to you. From the Japanese to the Indian mode or the US mode of Stryker, it's up to you. But it can have a very important role in delineating the vascularity of the flap. So as we come to the end of the talk, as I said, for trainees, it was a learning experience for us when we started try to re-understand the anatomy of the chest wall. We were used to using our diathermy and cutting the vessels and those small sputters being taken care of by the coagulation mode. People have attempted to reduce bleeding, ligatures and harmonics, so that there is no vessel and everything is sealed. And believe me, at times I have really gone mad when there is a big tumor and these vessels bleed a lot. Now, in the last 5 years, and very importantly, last 2 years, we have been able to understand that the neovascular pattern, that the neoanatomy one must understand, is right at the extreme medial aspect. You can have a nightcap, you can have here, and then you can have on the complete lateral aspect, the lateral thoracic artery perforated at the end, just behind the anterior edge of the latissimus dorsi. You can use the TDAP flap. But very importantly for breast surgeons, in the area between the lateral edge of the pectoralis major, and if you draw a line which goes straight on the anterior axillary line, this is the triangular area where you are likely to find the lateral intercostal vessels. You can, in most circumstances, we are going to use it with a Doppler, a handheld Doppler. We are planning to shift into a duplex scan in future once we get the instrument. And I'm sure people would like to see an ICG view after the flap is being taken. So for trainees, it's a complete new anatomy at the breast that we are looking at. And the use of these perforator flaps and moving them, either the propeller where it can move almost to 180 degree to just a small little mobilization to up to 90 to 120 degrees are well acceptable based on what type of perforators you are using. So the take-home message will be chest wall perforators are at the center of focus at this present moment. And we are seeing and we are observing that gradually the role of small mini-lat dorsi flaps is going into oblivion and it is being taken over by the LICAPs. And therefore one must understand that though the anatomical locations are quite constant and all of us have matured without a Doppler right at the beginning, very carefully understanding during a mastectomy where these perforators are, and then using a Doppler to understand as the standard of care how the vascular pattern is, either preoperatively or paraoperatively. CT angios and MR angios, in my own statement, would be more for microvascular and less for the LICAPs, where it's fine to use a Doppler. And if you're experienced, you can even give away with the Dopplers and start doing it once you're very sure where the anatomy is actually located. But what I am seeing is because of the fact that there is a very narrow spectrum of, things going wrong, one can couple up Doppler with an ICG to understand how the subdermal vascularity of the flap is. So as a gold standard, my statement for 2022 would be a Doppler, be it a handheld Doppler or combined with a Duplex, and an intraoperative assessment with an ICG to understand after you have deepithelialized and buried inside the skin flap to be very sure that this flap is not going to give away. For microvasculars, as I said, in difficult situations, you can choose to have a CT angio or an MR angio, but most of my microvascular colleagues are happy to use a Doppler and go ahead with that. So coming to the end, this is the new academic building which came up in last 5 years. The paradigm shift is not in terms of the academic building. The paradigm shift is the 4 floors above that you see here is being used for the COVID telemedicine for the whole state. And my junior colleagues have been asked to go there, and it's a 24/7 COVID telemedicine center in the top 4 floors. And most of us, while we are talking with these perforators, have been forced to understand the saturation of an individual in a different way from the saturation that we normally see on a perforator. And it's at the end of the day, be it an SpO2 of a flap, or be it the SpO2 of the COVID, which is the present paradigm shift, is taking a toll on us. I'm sure most of you also are taken and driven back into the workforce of COVID. So thank you very much for this opportunity, and I hope that the trainees would benefit, and if they want to begin their work on these chest wall perforators and imaging techniques, I'd be happy to help them. Thank you very much.
Thank you, Professor Deepten. That was a wonderful comprehensive review on the chest wall perforator imaging. So just to remind everybody, all the audience, this is the third talk in the series of chest wall webinar, perforator webinars, and this is mainly focusing on the imaging. You all have seen the field of breast surgery. That's a paradigm shift. In the last 2 decades, you have seen rapid advances being made. The field of oncoplasty, deconstruction, and perforator flaps is coming in a big way. So the modern surgeon, if this talk highlights that what are the skills we need to acquire if you want to take full-time breast surgery and to push your boundaries as a breast surgeon. It is not only the anatomy, but also you need to have a lot of basic knowledge regarding the imaging, diagnostic radiology and imaging. We need to work. Now the Doppler ultrasounds and ultrasound, portable ultrasound is becoming like a stethoscope for the subjects. So you need to practice. This is for the trainees. So everybody should have the basic understanding of the ultrasound, different modes, Doppler mode, and what are the imaging techniques, what are the fine points. You should be able to handle this. Coming to perforator flaps, I think Dr. Deepten has nicely highlighted the various current modalities that are being used. So what exactly you need to do is when you approach these patients, we have 2 situations. One is preoperative planning and mapping of perforators. Second is on-table assessment of perforators and vascularity. So there are different modalities because we don't have what a surgeon ideally needs is a real-time tool, on-site care. So that is where the portable devices are mostly useful intraoperatively. Under this category, I think the Doppler ultrasound and ICG have got a good role. They will play a major role in identifying these perforators. And CT angio and CT MR, as Dr. Deepten has said, are mostly for microvascular reconstruction and to get a good anatomical sort of a picture. But we need to remember there are specific protocols we need to follow for CT angio and MR angio if you want to really depict the anatomy of the perforators. Routine CTs and routine MRs will not give you these kind of pictures. You need to discuss with your radiologist. There are special contrast agents which will retain in the system for longer duration so that you can acquire multiplanar imagings. So there are specific protocols for CT angio, CT MRs. So you dig into these areas little deep and master the ultrasound, color Dopplers. And remember, when you do the marking of these perforators, the position of the patient is also important. So the marking, when you do preoperatively, it can be in the sitting or standing position. But then the patient is positioned on the table with the arm abducted, the landmarks may be a little different. So always keep these factors in mind and how to handle the probe. And coming to ICG, I think it is good for the perfusion assessment of the flap. But as far as marking of the perforators is concerned, because of the nature of the ICG imaging, there are limitations to use for marking the perforators. But of course, for flap assessment, it's a very good technology. We have been using at All India Institute for skin-sparing mastectomies, nipple sparing mastectomies. So we do assessment intraoperatively. So ICG is a good technique. Every breast surgeon should master it. Ultrasound and color Doppler, every breast surgeon should start routinely using these modalities. Even if you are not doing a LICAP or TDAP, keep probing for these perforators. You need to practice this, and you can master it by doing these things routinely. So this is just to sum up the entire talk. Maybe now we have a lot of senior people. We have a lot of delegates here. Maybe we can open up the session. We can take up some questions, maybe some comments also from senior faculty. Now I open up the session for Q&A session. So we have some questions coming in. I think one is on the cost of the ICG camera. There is one question from the delegates. Dr. Deepan, would you like to respond?
Yeah, I mean, if you want to invest ICG only for breast, the areas where ICG helps is number one, it helps in sentinel lymph node biopsy, it helps in reverse axillary mapping, it helps you after skin sparing mastectomy and flap perfusions. But beyond that, no institute should be buying an ICG. It costs between 80 lakhs to 90 lakhs. So it has to be a multidisciplinary use. I have used it for parathyroid localization. I have seen my colleagues using it for visualization of common bile duct. I have seen colleagues in cardiovascular where they can use it. So if you use it in a multidisciplinary manner, investing 80 to 90 lakhs will not be a big issue. We have a cheaper camera which was innovated in Bangalore. That is absolutely fine. You can use that camera. But as a comprehensive package, the best one possibly is the one that we have from Stryker.
Yeah, I agree with Dr. Deepan. You see, we have a whole range of machines coming into the field, ICG. The first generation was Novadac from Canada. We have that machine. It was acquired 8 years back. It was a very cumbersome machine, not ergonomically suitable at all. That's the first generation. But the new generation of Novadac was taken over by Stryker, which Dr. Deepan has shown. That they are actually marketing to from the range of, I think, 80 lakhs to 1 crore rupees. Unless you are using it for multiple areas like GI, cardiovascular, breast, I think the investment, we need to think about that. But the low-end fluorescent, the ICG imaging systems are available, as Dr. Deepan has said. The Arelic from Bangalore, they are marketing it for 10 to 15 lakhs. 15 lakhs. It is a portable sort of a system, handheld camera, ergonomically very good, and we have good experience with that. I have used it. Dr. Somshekhar has used it. And there is another machine called Flu Optics. It is a German machine. I have used that machine. It's a simple laptop and a handheld camera based system. They are marketing at around 30 to 40 lakhs. So there are 4 or 5 good players in ICG, but it all depends what is the purpose of your procurement and how deep are your pockets. These are the 2 things we need to keep in mind. Of course, the good thing is the running costs are very, very low because the dye is very, very cheap, especially the ICG dye. Any other comments or questions we can take from the lot of senior faculty? Dr. Nirja, would you like to add something, please?
Yeah, somebody wanted to ask whether how can you use ICG in lymphatic mapping of the arm? And one more question was, how do you handle the situation when you're not able to locate the perforators because of the spasm while doing the propeller LICAP? Very valid question.
Thank you.
So,
for the first question, for the mapping, for axillary reverse mapping, what we choose is we inject both intradermally and subdermally approximately 2 inches lateral in the medial groove of the axillary skin crease. And we rub it and wait for around 15 minutes. And if we find it's still not appearing, we can inject a bit more. But in most circumstances, if you use a combination of intradermal and subdermal injection, it glows up very nicely. And very importantly, you would be able to delineate the arm lymphatics right at the beginning from the point where it enters, going across the axillary vein and going up to the point where it enters into the thorax. It delineates the whole thing. So that's the technique. And initially we had problem, but gradually we have standardized. We did it on around 20 patients. It's doing absolutely fine. The second is the spasm. Yes, that definitely is a big issue. I mean, not quite frequently we use a complete propeller flap for LICAP. But yes, when we use the Doppler, the handling has to be very careful. and you can use the Doppler right at the beginning, intraoperatively, and this is the area where after you have put in the propeller flap, use an ICG to be very sure that the flap perfusion is quite nice. So these are the uncertain areas where a Doppler plus an ICG is going to help you out.
Okay.
Yes, I agree with this absolutely. For LICAPs, I would say, because these are small perforators to 0.03 to somewhere around half a millimeter, so it is always good to tap or maybe capture two LICAPs rather than a single one when you're trying to base a flap on LICAP. And that was a very lucid presentation, I would say, Dr. Dipton, and very well summarized by Sir Dio. I would add something to this with my experience, as Dr. Dipton just said. Handheld Doppler, and Dr. Dio has emphasized, handheld Doppler is something that suffices entirely. So if you know the surface marking of each and every perforator, for example, the L-tab, it just lies at the point where the lowest breast fold meets the anterior axial line at the level of the nipple, because that is the point, the fourth intercostal space, where the L-tab gives the perforator at the level of the nipple. So if you know the surface anatomy, I think Doppler, as you said, is the complete, the absolute tool which you can do with for raising a flap, and the intraoperative flap assessment. So once you raise the flap and you put your Doppler right there at the center of the skin paddle, and you get the sound of the Doppler, you are done. You know that the flap is going to survive. Nothing is going to happen. So I'm so glad to take up this topic with both Dr. Dipton and Dr. Dio. They have put in everything very nicely from A to Z, and I'm sure all the questions have been answered very well. Is there something which we are left with? We've got time, another 5 minutes, and then we wind up.
Yeah.
I think we're done.
Yeah. Other important tip I would like to add is for the trainees, have a mental map of the anatomy. Mental map of the anatomy. That's very important, because you are going with a tool and you are seeing the skin. Unless it is there in your mind what you are looking for, so it's very difficult to map these perforators. It will not tell you I am here, I am flowing like this. You have to imagine the anatomy, use the tool, then only you can map these perforators. So master the anatomy, have a mental mapping, then only the ultrasound and the patient will help. So that is a mental practice you need to do every time.
I also agree that while you are beginning your journey as a breast surgeon for simple mastectomies, use the mastectomies like a cadaver to understand where the perforators are. I'm telling you frankly, in a closed group, if you whatever you see, while I started localizing while doing a mastectomy, understanding where the perforators are coming, we sort of go very fast as we go on to the lateral axillary aspect. But that's where you should be very careful, delineating the perforators and understanding the anatomy. That's the trick. And then gradually build up on that. Go for YouTube videos, try to understand, go for a training course, learn Doppler. And as I said, while you are doing the pressure, that initially I was unable to locate in Doppler because I was pressing it very hard. Then I understood that while you are looking for a skin perforator, you have to be very light. The touch has to be very subtle. Then only it is going to pick up. And gradually, by trial and error, it came up. So as I said, you have to be very careful in the beginning through mastectomies and then learn the Doppler.
And the Doppler plays a lot of tricks also, because once you've localized preoperatively, the same thing doesn't reflect intraoperatively because of a lot of reasons. Maybe your jelly is less, or maybe your cover, the camera cover, whatever you use, it's harsh on it. But it definitely plays tricks once you shift from your preoperative to intraoperative. So it's a learning. The learning is a continuous process. It has to be step by step and continuous. We have to persist to actually learn any of the subjects. That's the key. So, very well conducted session. Thank you so much, Dr. Dipton. Thank you, Sir Dio. And I'm sure the audience has definitely enjoyed the talk and the discussion. Thank you so very much. See you next Saturday, same time.
Thank you.
Thank you, Dr. Incha. Thank you, Professor Dipton. Thanks all the delegates. Take care.
Yeah.
Thank you very much.
We can stop the recording, Uncle.
Okay, Dr. Nija. Thank you very much.
Okay, thank you very much. Take care. Take care.
Thank you. Good.
Ankur, do we have a Facebook live session with this? Are you there? Ankur.